Hey, good morning. I'm Dr. Paul Pepe. Been asked to talk about the best position for the patient during CPR, and so I'll give my 2020 vision of what that is. So first of all, before the main talk, of course, the usual four inevitabilities of life are, of course, death, taxes, and then, of course, someone like me making inane attempts at humor. And then, of course, there's disclosures. And so I can tell you that Dr. Pepe has no conflicts of interest to declare here, as we're supposed to tell you. But I have to admit that I am not a morning person. And so that's the one thing I do have to disclose. So I'm really glad that they've set this thing up in the virtual situation we have today. A lot of this should be deja vu all over again. I've been talking about this for a few years, but we're going to have some new teaching points as well and some new information that is not even published yet. So it'll be kind of fun for you to see this. All right. So one of the things that's going to be fun is that you're going to see we're getting back people alive that we never got back before. And it's been kind of fun to do that in the arena of out of hospital cardiac arrest or sudden death in the community. The potential flaws, let me start with this, that there's a potential flaws with the way we do CPR right now. When you're in a standard supine position, obviously it works, it's life-saving, but what's interesting is that it may not be optimal. And the reason why I say that is that when you press on the chest, it's standard chest compressions as you're compressing on a chest. One of the things that occurs, of course, is that you're setting pressure waves up the arterial side, but also up the venous side. So they kind of collide in the brain. And of course, obviously the arterial side wins out, but it's probably not as efficient. It'd be kind of cool if we could pull the blood out of the brain and allow for a better flow, a better cerebral perfusion pressure head, so to speak. So anyways, that's what leads us to the current talk. There have been several devices, some now that have been approved for use, such as the so-called impedance threshold device and the active compression decompression device. In fact, a study published in the Lancet about 10 years ago showed that they had a tremendous life-saving effect with neurologically improved outcomes. The reason why it works is that the intrathoracic pressure device, the ITD, the thing you see there on your left, is it's a little pop-off valve that could go on an airway. So if you do a compression, it's kind of like, I guess, like a turkey baster or whatever we call them, fluid baster from cooking. And as you release, then it allows a sort of a vacuum there, and that allows blood and air to rush in. What this thing does, it kind of caps the airway. And so in a way, it's like sucking through a straw. You're creating more of a vacuum into the chest. So in a sense, what you're doing is it's only on for a second, quick pop-off valve, but it's enough to tug a little bit more venous return. And of course, you're not only pulling from the rest of the body, but more directly in this situation, you're pulling it from the brain. Likewise, the active compression decompression device, although using a different mechanism, it's complementary and it does the same thing. It's pulling blood into, it's creating more of a vacuum, pulling more blood into the chest, and then and hopefully out of the brain. And so therefore, we're getting better flows up there. So here is a picture I actually took, I think, 20 years ago, in Paris, in which you can see how the chest compression goes down, and then there's a suction. And so you're actually enhancing better flow into the chest and out of the brain. So to investigate this further, our next step, as we're going to talk about, is that we have a team of people that work from the laboratory to the clinical situation. Our laboratory leader here is Dr. Johanna Moore. I wanted to make sure you understood that this is an incredible group of people working on both the clinical translation side and continuing work in the basic lab, as you'll see here. What we wanted to see is that just like it's like, I have a great R&D department, rip off and duplicate. In other words, we are taking from other disciplines such as the neurology, neurointensivists, neurosurgeons, and maybe creating a little bit of less intracranial pressure by a little bit of a tilt. So we are looking at the concept of, even during CPR, doing gravity-assisted CPR. Originally in the laboratory, I can't show you the animals, but the concept is to put a machine on like this. It's called the Lucas device, many of you know, and you can see it has that little pump in there, just like the thing I showed you before, the active compression decompression pump, and then, of course, an ITD. So we wanted to compare flat versus this is 30 degrees. It wasn't arbitrary. We picked 30 because in the animals, because that seemed to be optimal. If you went up higher than that, it was not as good. You dropped aortic pressure versus under that, it was not as efficient as what we're going to show you now. So if you look at 0 degrees CPR versus 30 degrees, you can see aortic pressures, intracranial pressure, ICP, and cerebral perfusion pressure. And sure enough, look what you get. You completely drop off the intracranial pressure without harming aortic pressure. And more importantly, your cerebral perfusion pressure goes way up. This doesn't look like a lot, but it's the scale. It's going from 75 to roughly 100. Interestingly enough, if you tilt the head down, because many people were thinking maybe we should do Trendelenburg when we're leaving, going down a stairwell or a hill or whatever it may be, and it turns out that that aggravates things. It just does just the opposite. So you start putting it up, the feet up, and look what happens. Intracranial pressure goes way up, and cerebral perfusion pressure goes way down. So clearly, in terms of best positioning, it looks like the head up to some degree, and I'm going to jump ahead and tell you in humans, it's more like 20 degrees or so. It's actually a number of centimeters that we use. But keep in mind, by the way, when I did this is something that's involving, a standard CPR rate of about 100 per minute delivered with a Lucas and ITD. And that becomes important to our next question that we're going to say, does it work without the ITD and active compression decompression devices? All right, so here is, I think, if any slide I take home, this is one of the most important ones to me. And then what you see here is that we're looking at cerebral perfusion and pressure here, cerebral perfusion pressure. And this is, by the way, a modification where we have the head and shoulders up a little bit with the thorax elevated a little bit as well, mostly the head. And here's your cerebral perfusion pressure at baseline. And then as the animals are put into cardiac arrest, of course, the pressure falls off. And here they begin CPR on this bottom one. If you can see the color, it's purple. But as it goes off, all of a sudden, it actually goes into negative territory. It's not so good. Why does that happen? Well, what happens, you're losing your pressure head largely because there's peripheral vascular relaxation. You no longer have vascular tone. It's going away. So this is less effective. So interestingly enough, if you put, and as you see here in our chart, if you put the head up, it's actually better, and it sustains over this next 20 minutes or so, much better perfusion pressures if you keep the head up. However, if you do the active compression decompression device, and this probably gives you a reason why we had the good outcomes clinically, as you can see, it not only is better, but it sustains it for a longer time. So it gives you more terms of more effectiveness for a longer period of time. And this is out here again, 20 minutes in this resuscitation model. But here is what it's all about, I think, is that if you now add head up with active compression decompression, as I call it, enhanced CPR with the ITD and ECD, you get this effect here. It's not only better, but it's not additive, it's synergistic. So the combination of these three things that help to pull blood out of the brain and into the chest basically are coming together and working with complementary mechanisms, but they work to make a big difference. And just to quickly jump ahead, we've now looked at that by keeping the chest up a little bit, you're lowering pulmonary vascular resistance. It has better mechanics, just like when a patient has pulmonary edema, they do a little bit better when they're up in that realm, and it helps get more blood through the chest as well. So what about people? Is there any clinical experience in doing this? All right. Well, it turns out that we actually did some translational models with cadavers and then eventually have gone on to people. And one of the first things we did was about 5 years ago, quite frankly, but we did a very crude model of a reverse Trendelenburg just for want of having a better procedure, so we could put a machine on so we could have, let's say a chest compression that is reliable, and we know it's deep enough and we know it's at the right rate and so on. So in any event, our resuscitation rates in this place where we did this in Palm Beach County, which is a very diverse county of extremes of wealth, extremes of various diversities of populations. So it's the county versus, say, West Palm Beach and Palm Beach itself, where a lot of the wealthy people live. This is a very diverse population, geographically spread out. And so they were doing pretty well in terms of resuscitating people by them on a monthly basis in 2014. But in January, it stayed about the same. I was contacted in February to help maybe introduce this process down there. We did some training in February and we got it launched in March. And over the next 2 months, we were able to dramatically increase resuscitation rates. Now, I, at first glance, said, this is a historical control. This doesn't, whatever. But going back to the other slide, they had already been using the ITD and the active compression decompression device. And granted, we do some training and so on. But bottom line was, this was profound as we went from station to station, adding this one new thing in. So we have published that since then. I think it came out last March. maybe a year ago in March in 2019, and about confirming the feasibility of this approach of raising the head up, using the ITD, and so on. So what's interesting is that this is not a standard deviation. This is actually a range of quarterly outcomes. And you can see when we introduce it, it goes up dramatically and doubles it. So this was pretty profound. And other systems have now, EMS systems have now adopted this. About 40% of the people who resuscitate and get to the hospital alive, because that's what we're looking at here for standardization, about 40% of them go home neurologically intact. This has been really amazing because it's really saved a lot of lives. So our conclusions have been that head and chest up work, and they likely work really well. They likely improve neural outcomes, but it depends on having also that enhanced CPR with the ITD and the active compression, decompression, and that both heads up and chest up are better. And I think the big issue here is that lowering ICP during CPR should be a new focus, but it's not truly ready for prime time yet, and let me explain why. So the next phase in our research has to do with a gradual raising of the head. If you just bring the head up right away, it doesn't work. You've got to prime the pump. In fact, it may be deleterious. So what we've learned is to start the active compression, decompression, the ITD, and then we gradually raise the head up, and we've used this automated approach in the laboratory. And I think now they probably, I call it device-assisted control, or DAXI, of the head and thorax. And we start that a few minutes in, and then it takes place over 2 or 3 minutes, and then it works really well. This is I think it's a proprietary model. Again, I don't have any conflict with it, but that is going to be tried out. But the cool part is we saw the slide before with the active compression, decompression being better than standard CPR. But look at this. If you go back up here, the DAXI physiology, it improves dramatically and more over time. And what's interesting is now in the clinical setting, we're having to use sedation for people who are still, say, in refractory VF. It really does well. And the preliminary lab data before we brought to the field showed that we were increasing CPP to 90% of pre-arrest values. And it improves the neurological favorable survival, at least in the laboratory, 6-fold. And the reason why it's 6-fold is that 6 of 8 versus 1 of 8 were resuscitated with neurologically favorable outcomes. But nonetheless, it's pretty profound, and you see the difference. And then the next step was that this thing, you can actually get more tug, so to speak, and create more of a vacuum. So we've now done some recent research adding that into the mix. This is something we presented earlier this year. I have not published it yet. I'm hoping to get it done here fairly soon. But what's interesting is the preliminary first 6 months has been that 42 cases, most of whom were 31 were asystole cases, and 71% got a normalized end-tidal CO2 within a matter of minutes by using this approach. And 42% got the return of spontaneous circulation versus, for these asystole non-shockable rhythms, 31% with the reverse Trendelenburg versus previously when we had 13% flat. And nobody had problems with using this. It is bulky, it's a problem, but it's fun when they get them back. And as you can see here, as we've gone from conventional CPR to the stretcher elevated up to the DAXI, we're getting better outcomes. So it's become very popular even amongst payers, so on. But let me tell you one more step here. After return of spontaneous circulation is one more thing I want to add in. This is all brand new right out of the lab, and we're thinking we're going to get people back after we resuscitate them if we use this. So we just happened to notice in the laboratory that when we started putting the animals down after doing a study, their regional SO2 went from 75% down to 68%. And so we raised them up again and goes to 75%. So we were able to reproduce this. So we think, and we now have some cerebral perfusion data, that you actually do much better if you're with a mild head-up position after resuscitation. That's assuming you have a good aortic pressure developed and so on. All right, so anyways, what's the future? The future is that, and what's the takeaways here? I think the takeaway is that I look at this more as a new concept in CPR. It's probably a major advance in our physiology of this and thinking about it that involves a synergistic bundle interventions. And that includes not only the head up, the active compression decompression device, the ITD, everything to the interthoracic pressure regulation, but of course, giving a large lung inflation and allow blood to travel through, and then not giving it that often so that you don't increase intrathoracic pressure. So there's a lot of things, and we've developed a paper that's just been accepted for publication in Critical Care Exploration. Should be out fairly soon, or maybe by the time this talk is given, called The Rationale and Strategy for Developing Optimal Bundle of Management for Cardiac Arrest. And I hope you'll enjoy that. And it talks about some of these things in there. So thank you very much. It's been a privilege to talk to you. I hope I didn't go too fast, but we covered a lot of material. So thank you so much.